your question. Right. So if you have read and understood, considering your surgical pathology station, kindly discuss about your provisional diagnosis.
So my provisional diagnosis for this case would be a multiple endocrine neoplasia type 1, possibly patient is suffering from pancreatic adenoma or more specifically insulinoma.
Okay. How would you confirm your diagnosis?
So for confirmation of my diagnosis would be, first of all,
yes, has already been
would
done.
you,
Yeah.
okay. Since CT scan has already been done, I would like to do a blood test in which I would like to check the serum blood glucose level, which is usually would be less than 2.5 millimole per liter blood glucose level. Then there would be high levels of insulin, which is high levels of insulin that is more than 10 to the power 10 more than 10 micromole per liter. Then high levels of C-peptide, proinsulin, and also there would be a high insulin to glucose ratio.
Okay, can you please tell me why do you see hyper enhanced lesion, pancreatic lesions in the CT scan?
Possibly there is a pancreatic adenoma, which is
Okay.
that is why there is this hyperenhancing pancreatic lesion.
Can you describe or explain the term adenoma? What do you understand by that?
Adenoma is a benign tumor arising from epithelium which shows glandular pattern,
Yes.
or exhibits which has glandular function or exhibits glandular pattern.
Okay, how would you how would you confirm? You've already told me, just suppose if it is insulinoma. So what do you understand by the term Vibe stride?
Whipple stride is the manifestation as seen in insulinoma, which shows that there is that the clinical symptoms occur such as confusion, stupor, coma, and where blood glucose level would be less than 2.5 millimole per liter, which is precipitated by either fasting or exercise and relieved by taking either oral glucose or by feeding or by parenteral glucose administration.
Can you okay, you've told me it could be hyperglycemia, but can you mention few other reasons of hyperglycemia?
Yes, there could be
yes.
Yes, there could be nesidioblastosis, liver dysfunction, then inherited glycogenesis. Then it could be ectopic insulin secretion by retroperitoneal fibroma or sarcoma. Then it could be abnormal insulin sensitivity, and yeah.
Okay, one sample has been taken to confirm, and it has been seen under the microscope. What would you see?
There would be increase since this is an insulinoma, so there is an increase in the number of the beta cells within the pancreatic islets, and increase in the
there are many other things as well, like there'll be increase in the oxyphil cells and delicate fibrous strands.
Ma'am, that is in parathyroid gland.
Okay, that's parathyroid? I'm mixing.
That's in parathyroid gland.
Yeah.
But if we take biopsy from the parathyroid adenoma, in that case, we will
No,
see
insulin-
that there is an increase
Yeah,
in chief
insulin.
cells
Yes.
with islets of oxyphil cells. Yeah.
Okay, how would you, rule it out from MEN2 syndrome?
In MEN2 syndrome, patient usually presents with either medullary carcinoma of the thyroid or a pheochromocytoma or hyperparathyroidism. Along with that, patient will have a morphonoid habitus and mucosal neuromas.
What are the genes which are present in
The
case
gene
of MEN2 syndrome?
in MEN2 syndrome, there is chromosomal abnormality on the chromosome 10 ret gene.
Right, and what is AD? Okay.
That is, then there are other genes would be such as the autosomal. These are
Dominant,
autosomal dominance.
yes.
That is alpha thalassemia mental retardation gene. Then there is the which is
What are
X-linked.
the
Then
two important tests that you can do to confirm MEN2 syndrome?
I could check the confirm for that. I could check the first. I would do a full body CT scan to exclude any carcinoma of the thyroid or in the pituitary or parathyroid, and also I would do a urinary vanillin and mandelic acid to exclude pheochromocytoma. Circulating metanephrines could be checked, and yeah.
What should be the management that can be offered to this patient?
It depends upon where at what side the patient is, the symptoms of the patient. If the patient presents with a pheochromocytoma, then we'll have to go for excision adrenalectomy. Then if the patient is coming for medullary carcinoma of the thyroid, in that case, we can go for hemithyroidectomy with a block neck dissection. And yeah.
Okay. There is one scenario. There is this 40 years old lady who got pathological fracture of femur shaft while cycling. So in that situation, what would you think the pathological fracture is?
So this could be post-menopausal, and
Yes.
also the fracture is basically a crush fracture, so it could be post-menopausal. Also, other diseases that we could consider is osteomalacia, as in vitamin D deficiency. It could be simple bone cyst, or it could be primary bone tumors, or it could be metastatic bone tumors, multiple myeloma, then Paget's disease of the bone, and inherited diseases such as osteogenesis imperfecta.
Okay. You've done the histology of that particular patient, and there are follicular cells which are seen on the histology report. So what would you consider or think the origin of the carcinoma was?
So this is okay. The primary site is in thyroid. This is a case of follicular carcinoma of the thyroid that has spread to the bones.
Can you mention other carcinomas that can metastasize to the bone as well?
It can breast, lungs, kidney, prostate.
Good.
And thyroid.
Right. So if a pathologist wants to confirm the origin was from thyroid, how would he or she would do?
By doing immunohistochemistry.
Yes. Okay.
So immunohistochemistry, yeah.
Oh, yeah, or they can even do the FNAC. All right.
Yeah.
What would they see in that?
In immunohistochemistry, it will allow to see the origin of the cells. That is, it will check the number of. It is
antigen
based
antibody
on,
reaction.
It is based on antigen antibody. It is based on antigen antibody reaction, and here the specimen is inserted in a solution which is consisting of an antibody and a dye or an enzyme such as a horseradish peroxidase enzyme. That is labeled with another and a chromagen or a dye is added, such as a benzodine is added, and then when there is the antigen from the specimen binds to the antibody in the solution, then it lights up under the light microscope. This is it gets activated, and the dye can be seen under the microscope, and
Yes,
it follows the complement fixation reaction.
yes, but we don't do that for radioiodine scans are not done for thyroid involving carcinomas.
In that case, we will go for thyroid, we'll go for FNSC, or we can go for biopsy.
Okay.
And
in
isotope scan.
In FNSC, what type of cells would you see?
In FNSC, there would be follicular cells
Yes.
showing different degrees of dysplasia. And I'm sorry, ma'am, I'll get back to that later.
There's one, okay, there could even be medullary cell carcinoma of the thyroid as well, or the follicle. So they could be both.
Yeah.
There is possibility. Okay, good. Right. Thank you so much.
Thank you.
That's good. Thank you.